Good morning. Welcome to the sixth webinar session of the Department of Health and the Philippine College of Physicians. And certainly, this topic is one of the most important problems that we're having. Particularly, we have the basic problem when we started seeing the COVID cases, which have become severe, and we have observed and found out that most of the patients who develop severe illness are the elderly, as well as those who have pre-existing conditions or comorbid illnesses. And therefore, for this particular session, we'll be focusing on COVID-19 in the elderly and the vulnerable, which means these are the group that have comorbid illnesses or pre-existing conditions that somehow make their disease or problems becoming more complicated. And of course, that's time that we also need to prioritize this group of patients, particularly those who are predisposed, or gonna have this risk of exposure to have COVID disease. Now, for today's webinar session, we are fortunate to have three great speakers, who certainly can give us light and lots of information with regards to this group of patients. First is, of course, my colleague, my co-member of the Philippine College of Physicians Board of Regents, Dr. Nemencio Nicodemus. Nemi, as we fondly call him, is a professor of the University of the Philippines College of Medicine, Department of Biochemistry and Molecular Biology. He is also a clinical professor of the Division of Endocrinology, Diabetes and Metabolism under the Department of Medicine at the Philippine General Hospital, where he is also the residency training officer. He's currently the vice president of the Philippine Association of the Study of the Overweight and Obesity, and the president of the Philippine Thyroid Association. And he is the past president of the Philippine Society of Endocrinology, Diabetes and Metabolism. Sorry for flashing this late, but these, of course, those credentials that I have mentioned. Our second speaker, or second, of course, in the group of speakers that we're having today, is Dr. Vimar Luz. He's a graduate of the adult nephrology at St. Luke's Medical Center at Quezon City. He's a fellow of the Philippine College of Physicians and the Philippine Society of Nephrology. He heads several dialysis centers in Metro Manila and is an active nephrology consultant at St. Luke's Medical Center QC, where he heads the Center of Organ Transplantation and the SLMC Global CT, serving as a training officer at the Center for Renal Diseases. His research interests include the critical care nephrology, AKI or acute kidney injury, chronic kidney disease prevention, and hemodialysis. He is currently a board member of the Philippine Society of Nephrology. Last but not the least is the only lady in the group of speakers today, Dr. Lourdes Carolina Dumlao. Sandy, as we call her, is the current president of the Philippine Society of Geriatrics and Gerontology. At the same time, she is the secretary of the Philippine College of Geriatric Medicine and one of the board of directors of the Alzheimer's Disease Association of the Philippines. She is an active consultant to the St. Luke's Medical Center, both in QC and in Global CT, as well as of the Victor Potenciano Medical Center. So we will start, of course, with the discussion of COVID-19 among the elderly, followed by the discussion of diabetes and obesity in relation to COVID-19, and of course, COVID-19 in relation to kidney diseases. Okay, so let me pass, of course, to Dr. Sandy Dumlao.
Good morning. Can you see my screen? Can you see my screen?
Yes, yes.
Okay. All right. Good morning, everybody. Thank you to Dr. Paneligan and the Philippine College of Physicians for inviting me. So, what I will talk about is COVID-19 in the older person. And these were the objectives that were given to me that I will try to discuss all of this in my short lecture. Okay, so this is the Philippine situationer as of yesterday. There is a total of 12,305 cases with 2,561 recoveries and 817 deaths. Um, I don't know why it says May X, so I don't know how recent this is. But if you look at the age and sex distribution of cases here in the Philippines, you will see that majority of the cases is actually in the 20 to 39 age group, with the least number of cases in the pediatric, followed by the geriatric age group. This can probably be explained by the fact that these are also the two age groups that have been strongly discouraged from leaving their homes during the ECQ this past 2 months. This is the WHO Philippine Situation Report, the latest, which was May 13. And again, if you look at it, it is consistent, showing that those in the age group of 20 to 39 are your highest number of cases, and your pediatric and your geriatric age group are the ones with the least number of cases. However, if you look at the age distribution of deaths, you will see markedly that for your senior citizen age group, your 60 to 69 and your more than 70 would have the greatest amount of deaths. So, in fact, a total of about 67% of those patients who are 60 and above would not actually survive getting COVID-19. So, this is obviously a case for concern. Okay. But why is COVID-19 more lethal in older adults? Of course, we always want to blame age. We say that the older you are, then your lifespan is obviously shorter and you are more prone to getting disease. But we don't want to just say that it is age alone. We've seen from the studies done that patients with comorbidities, especially hypertension and diabetes, are also more likely to suffer from the severe disease, as well as higher mortality rates. And unfortunately, the older patients are also the same patients with more comorbidities. As many as 62% would have hypertension, and as many as 47% would have diabetes after the age of 60 and above. Of course, there are also some genetic variabilities. There are anecdotal reports in other countries of patients who are 100 years old and above who have actually survived COVID-19 and were able to be sent home. So just talking about age alone would not be enough to say that these patients will not be able to recover from the disease. One very important hypothesis, which has been mentioned before in other diseases for older patients, is immune senescence. We know that the older we are, our innate and adaptive immune system also becomes weaker. So it wanes and is not as effective as the younger patients. So much so that with aging, we have fewer naive T cells, we have less efficient natural killer cells, less B cells that will enable us to produce antibodies. There's also less efficient communication between the natural killer cells and the activated T and B cells, which causes an overdrive in the initial response, ultimately leading to our cytokine storm. Okay. So what are the risks that are actually particular to the older person? We've seen that fever, fatigue, cough, anorexia, myalgia, and dyspnea are some of your more common symptoms. But we also know that a lot of older adults will not present with your typical symptoms, especially your frail older adults with multiple comorbidities. When we talk about frailty, we know that the physiologic reserve of older individuals is not as efficient as younger individuals, so that the body's capability to fight off any illness or any infection is not as good. So in these patients, they may present as a febrile, which is your most common manifestation of COVID-19. They may not have a cough, they may not complain of chest discomfort or have sputum production. Some anecdotal reports in long-term care facilities in other countries report tachypnea, altered mental status or delirium, unexplained bradycardia, and decrease in blood pressure as the presenting clinical manifestations. Other anecdotal reports also say malaise, muscle pain, low-grade fever, and cough, which are relatively mild, would just suddenly progress to respiratory difficulty during the second week of illness. Additionally, you have a subgroup of older patients with dementia, those who have already suffered from strokes and other health conditions, which may also mask the symptoms of COVID-19. So much so that right now, what we say is any change in baseline clinical status that is sudden or acute with no evident explanation would actually merit an evaluation for COVID-19. Okay, my screen froze. There. Sorry, my screen is freezing. Okay, I think the slide before this was just reiterating the point that for older patients who do have COVID-19, the risk for severe disease and mortality is high. Those who are 80 and above who would get the disease are five times more likely to die of the disease compared to the other age groups. And this is most evident in the data that Italy has shown, especially in their initial city of outbreak, which was Lombardy, which is mostly made up of senior citizens who are active, where they had a 38% mortality rate compared to China, which had about a 12% mortality rate. And I think if any of you are familiar with the term ageism, there is no time wherein ageism is more prevalent than now during the time of the pandemic, because a lot of our medical decisions have also been forced to be made based on ageism. So there is a lot of discrimination happening, especially with the high rates of infection in older patients versus the lack of medical facilities and medical equipment, so much so that there have also been anecdotal reports wherein if doctors had to choose between saving a young patient and saving an older patient, it's the older patient that would be sacrificed. Can you still see my screen? Hello?
Yes, Sandy, yes.
But it's freezing on my end.
It's freezing again. Ayaw gumalaw.
Okay.
Sorry for that. Yeah.
Okay. So, ironically, one of the things that would increase exposure and infection in the older person is their home situation. So, culturally, we have families and extended families living together, so that an older person would probably be living with several other people in the home, and that overcrowding could actually increase the risk of infection simply because family members would need to go in and out of the house in order to work or get basic necessities like going to the grocery or buying medications. But at the same time, you also have older persons that live independently, which also increase the risk of exposure because they themselves would have to be the ones going out of the house in order to buy food or medications. Those quarantined are also at higher risk of neglect and abuse. There have been increasing reports of verbal and physical abuse of older adults from family members or spouses, and also neglect. So being quarantined is stressful, not just for the older patient, but even for a healthy individual. So if you put them all together, stuck in a house, then you can have more psychosocial issues and not just physical ones. Okay. And of course, we've all heard about the initial outbreak in Seattle, Washington, which started in a long-term care facility, which actually had the first clustering of cases there. Although here in the Philippines, we don't have as many long-term care facilities and nursing homes, we still do have them. And because most of the residents in these long-term care facilities are older patients, they also become more vulnerable. Okay, for some reason, it keeps freezing. Okay, the Center for Disease Control, which is my next slide, has actually come out with guidelines for long-term care facilities and nursing homes in order to contain the spread of COVID-19. Sir, my screen is still freezing.
I just vibered you. Maybe you can try um, stopping first and then entering again for the screen share.
Okay.
So stop the presentation and then just re-enter again. Can you re-enter now? Yeah. Yeah, Sandy, can you re-enter now?
Yes, sir, but it's still frozen.
Mm-hmm.
Sorry.
Dito sa akin kasi meron na yun sa'yo, yung slide mo.
You can try turning off the video also, Sam. Turn off the video muna.
Paano ba to?
Ayaw eh. Parang nag-hang na.
Anong advice natin?
Does Dr. Nemi want to go ahead first?
Okay nga po, Dr. Kung pwede naman po.
It's just frozen on my end.
Yeah, maybe yun, ang suggestion ni Wimar, i-turn off mo muna kahit yung video mo. I mean, even the sharing, stop mo muna. And then, we'll ask Nemi to give his lecture.
Okay. Sige, sir.
Sige. Nemi, can you present your lecture slides?
Yes, I'll just wait for the slide to be unshared.
Okay. That's it.
Sir Panaligan, maybe you can remove the slide of Sandy. Baka hindi rin niya matakot.
How do I... Nemi, for a while, we're fixing it here.
It's okay.
Apologies for our participants. Just for a while, we're fixing it now. Sorry. Nemi, can you try now?
Okay. Can you see my slides?
Yes,
Okay.
yes, Nemi. Thank you.
Good morning. While we are waiting for our first speaker to fix her system, I will be starting with the second talk. And my part of this particular webinar will be COVID in the vulnerable people with diabetes and obesity. And as given to us, we want to elucidate the risk factors related to severe illness due to COVID 19, discuss the approach in handling the vulnerable patients, in my case, diabetic and obese patients, and to explain the acknowledged interventions to decrease complications and mortality, and enumerate the best measures to prevent COVID 19 among people with diabetes and obesity. Now, why do we have to single out people with diabetes and obesity as part of the vulnerable set of our population? This came from the Centers for Disease Control and Prevention in America, and according to them, the people at higher risk for severe illness from COVID 19 include the older adults, and that's why we have our first speaker, and people of any age who have serious underlying medical conditions. And let me highlight that according to them, we should consider at higher risk for severe illness those with severe obesity and those with diabetes. And the speaker after me will be talking about chronic kidney disease. And so let us focus on these two conditions, diabetes and obesity. Let us start with people with diabetes and how many people actually with COVID 19 present to us with diabetes as a comorbidity. In order to answer that, let me share with you the result of a meta analysis of several case control studies published between January to April this year, looking at the pooled prevalence of diabetes. And you can see here that in general, people with diabetes have the same risk of having COVID 19. But if we look at the overall population of COVID 19, approximately 1 in 10 patients with COVID 19 have diabetes. And so they are indeed a very important subgroup of patients whom the healthcare provider has to see on a regular basis, either as part of those people quarantined or as part of those people admitted to several hospitals. And perhaps the next question would be, why would diabetic people be a special subset of people that would acquire COVID 19? Let us review very briefly how the SARS-CoV-2 virus, which is the causative agent for COVID 19, enters the body. We all know that the structure of this particular virus is such that it has spike proteins around it, and these spike proteins are the ones that attach to special receptors that will allow it to enter the host. And in this case, one of the receptors that has been identified is none other than the angiotensin converting enzyme 2, or the ACE2, which attaches to the spike protein of the SARS-CoV-2 virus. Aside, however, from the ACE2 receptor, there's another receptor, the transmembrane serine protease 2, which also serves as another coenzyme allowing the entry of the SARS-CoV-2 virus into the host. Once inside the host, the virus now utilizes the nuclear machinery of the cell in order to replicate itself and cause damage. What we must, however, note is that ACE2 is part of the subgroup of family of receptors, which also includes the angiotensin converting enzyme, or the ACE. As we all know, the ACE converts angiotensin 1 to angiotensin 2, but the ACE2 converts now the angiotensin 2 to angiotensin 1 to 7. And this particular receptor, the angiotensin converting enzyme 2, or ACE2, is found not just in the lungs, but can also be found in the kidney, the heart, and even in the pancreatic islets, where it may cause damage to the pancreas, leading now to destruction of beta cells and eventually insulin deficiency. But just to tell everyone that in fact angiotensin converting enzyme 2, or ACE2, is really part of the normal body's response to certain injuries. And in fact, when you convert angiotensin 2 to angiotensin 1 to 7 via the ACE2, you create now this particular anti-inflammatory, anti-proliferative, and vasodilative property of angiotensin 1 to 7. But what happens is, in people who are sick with the SARS-CoV-2 virus, there is now the attachment of the SARS-CoV-2 to the ACE2, and thereby you downregulate the amount of the ACE2 that you find in the cell membrane. And this is the reason why, aside from affecting not just the lungs, the SARS-CoV-2 virus and COVID-19, therefore the disease, will affect not just insulin secretion, but it can also have a potential damage to the brain, to the kidneys, and even cause thrombosis, because as shown in this illustration, it is the endothelium which is dysfunctional, and because the endothelium contains ACE2 as well, this can explain why several organs may be dysfunctional as a result of the infection with the SARS-CoV-2 virus. But even if people with diabetes are not at increased risk compared to the general population of contracting the virus, when people with diabetes do have COVID-19, in this meta-analysis, they were able to explore the relationship between disease severity and mortality among people with diabetes affected by COVID-19. And in these studies, they were able to show that people with diabetes and COVID-19 have increased risk of severe disease. In fact, it's twofold increased risk of severe COVID-19 and also twofold increased risk in mortality due to COVID-19. And so indeed, this vulnerable population is at higher risk of severe disease and of mortality due to COVID-19. What could be the reasons why there could be increased severity of COVID-19 among people with diabetes? There are established factors and there are also postulated factors. Among the established factors, as we all know in general, is glycemic instability. We all know that hyperglycemia, if it is uncontrolled, is associated with poorer immune response, and even in cases where they are controlled, they might have hypoglycemic episodes. Secondly, you have immune defects found among people with diabetes, like impairment in T cell response. And we all know that diabetes doesn't go by itself but is associated with obesity, heart, and kidney diseases, as will be discussed by the third speaker. The postulated reasons for increased severity of COVID-19 among people with diabetes include chronic subclinical inflammation, which is present among people with diabetes and even obesity, increased interleukin 6, plasmin, and a reduction in the angiotensin converting enzyme 2 or ACE2, as I have mentioned, because there is a downregulation of the receptor whenever you have a lot of the SARS-CoV-2 virus attaching to these membrane receptors. Also, there is an increase in furin, which is postulated to be involved in the entry of virus into the cells. But it's not just a one-way interaction between diabetes and COVID. And in fact, COVID in itself also exerts a negative effect on people with diabetes, further contributing to hyperglycemia. This, of course, involves the beta cell damage, as we mentioned, that results now to relative insulin deficiency. The presence of inflammatory cytokines can increase insulin resistance. The presence of medications that are being used currently in order to control and to treat the COVID-19 involves steroids, and even some of these medications that may further increase hyperglycemia. And so indeed, it is a two-way interaction between COVID-19 and diabetes, both now leading to hyperglycemia. When we talk about certain medications that are associated with hyperglycemia, among the therapeutic agents that are now known to have to cause hyperglycemia, of course, include lopinavir and ritonavir, which can cause, of course, deterioration of glycemic control. And as we all know, steroids also increase blood glucose among our patients and further increasing susceptibility to secondary bacterial infection. After diabetes, the other vulnerable set of populations are those with obesity. And why would you think that a person with obesity be more vulnerable to development of severe COVID-19? This diagram illustrates to us what happens in a patient with obesity. It actually induces a pro-inflammatory state with increase in your pro-inflammatory cytokines and a reduction in the beneficial adiponectin. As a result of this, you have endothelial dysfunction, as I have mentioned a few slides ago, which now results in a reduction in the nitric oxide and an increase in the reactive oxygen species, which now all lead to alterations in lipid and glucose metabolism, atherosclerosis, insulin resistance, and hypertension, of course, all of which are part of the metabolic syndrome. And it has been shown that if you are obese, aside from increasing leptin and resistin, which increases the insulin resistance, there is also the effect of the ACE2 receptor, which, as we have talked about, acts as a receptor for the SARS-CoV-2. And if you have increased insulin resistance, you have hyperglycemia, you can also have hypertension, and with the entry of the virus, this makes the obese individual at risk for more severe COVID-19 infection. Is this seen among patients who were admitted for COVID-19? I'm showing you now the result of patients who are admitted in the ICU for COVID-19, and they were categorized depending on their body mass index. On the left, people with no SARS-CoV-2. On the right, those with SARS-CoV-2 infection, and you can see that those on the red bar, part of the bar, the ones with more severe obesity, are predominantly seen among people infected with SARS-CoV-2 virus in the ICU. And not only that, if you look at the distribution of the body mass index, those that will require mechanical ventilation are the ones that are more obese in terms of their body mass index. And if you look at the proportion of patients requiring mechanical ventilation during their stay in the ICU, again, people with the heaviest BMI, the largest BMI, are the ones that would require mechanical ventilation compared to those with lower BMI. Just telling us that indeed obesity also is another condition associated with more severe COVID-19 requiring mechanical ventilation in the ICU. Having said that diabetes and obesity are conditions that are associated with higher risks of more severe COVID disease, how do we take care of our patients with these conditions? The food and nutrition requirements or recommendations that come from the World Health Organization, particularly for patients with obesity, include limiting salt intake, limiting sugar intake, limiting as well the fat intake, and consuming enough fiber. Aside from this, of course, we want our patients to stay hydrated and to avoid alcohol or at least reduce their alcohol consumption. And finally, enjoy family meals. Of course, we can choose what kind of food we need to serve during family meals. Aside from that, the World Health Organization also recommends staying physically active, especially during the quarantine days. Among obese individuals, they should take active breaks during the day. They should follow online exercises because by now, of course, we all know majority of the gyms are closed. They need to walk more, even if just inside the house. Stand up more often rather than sitting and watching television or even being in front of the computer. And finally, part of the recommendation is also mental health, and definitely relaxation should be part of the activity that we should be doing on a regular basis. These are just some of the exercises recommended by the World Health Organization that can be performed at home with very minimal equipment. In fact, most of them would not require any equipment at all. And as you can see, they are just requiring the person to use his own self and his own weight as, of course, the instrument for these particular exercises. And the recommendation is to perform these moderate intensity activities for at least 150 minutes per week or 75 minutes of vigorous intensity activity per week, or a combination of both. And so indeed, nutrition and physical activity are very important, not just for obesity, but also for diabetes. But in general, if we are going to prevent and manage our patients with diabetes and obesity, first and foremost, we want to prevent the infection. And this will include, of course, making sure that their blood glucose is well controlled by regular monitoring, regular intake of their therapy, using an adaptive lifestyle that includes nutritional and physical activity improvement, minimizing exposure to the SARS-CoV-2 virus by staying at home, and of course, the use of other drugs that will control comorbid illnesses. But for those patients who already have the COVID-19 disease, it's important that we still maintain good glycemic control. In asymptomatic patients, make sure that they continue their usual therapy while staying at home or in a quarantine facility. For those who have symptoms but are not severe and are admitted in the hospital, we must withhold certain agents that may cause some dehydration, like your SGLT2 inhibitors, but more importantly, control their blood glucoses using insulin. And of course, in the ICU, the important modality of treatment to control glycemia would be insulin, either in the form of multiple doses of subcutaneous insulin or in critically ill patients, the use of intravenous insulin. Let us not forget that all throughout this time that we are controlling their blood glucose, we must also be giving them drugs that will control comorbidities like your ACE inhibitors and ARBs, your statins, and even aspirin as necessary. And of course, prevent secondary bacterial infections. And in cases where patients will be at risk, of course, because of their exposure, we might need to give them vaccines for other conditions, of course, other viral illnesses, and may even need post-exposure prophylaxis and immunomodulators. Of course, in all of this, we know that we need to adapt our healthcare services. And what are the strategies, the adaptive strategies in healthcare? We must recognize that people with diabetes and obesity are a vulnerable group. And therefore, we must make sure uninterrupted self-care of these chronic diseases, making sure that they use resources that are available in their community, make sure that we give them preventive and curative interventions urgently. And of course, in this particular pandemic, it's important that we look at researches and make this as our priority. And very important, capacity building and emergency preparedness. And so, with this particular short talk, what do I want to share to everyone? That patients with diabetes are at higher risk of developing severe COVID-19 and dying from it due to metabolic and immunological factors compounded by comorbid conditions like obesity. Patients with diabetes and obesity should be advised adaptive lifestyle that of course includes diet and physical activity, regular monitoring and vaccination as needed, and that glycemic control and weight loss may reduce complications and mortality related to COVID-19, and this should now be part of the control of the comorbidities that we do while observing measures to minimize exposure among these vulnerable sectors of our society to COVID-19. Thank you very much.
Yeah, thank you, Dr. Nicodemus, for that enlightening talk, and certainly we appreciate, of course, the newer updates. Let us now hear, Dr. Sandy Dumlao, to continue her talk earlier.
Okay, my apologies for the technical difficulty. So I think I sent my slides to you already. So can we start from the slide that says vulnerability and neglect? Slide number 12. Okay, so yeah, this is fine. So we were talking about the increased risk of older persons who are usually your patients in long-term care facilities and nursing homes. And we've seen that there has been outbreaks in these kinds of facilities in other countries. So the Center for Disease Control has come out with guidelines in terms of spread and prevention of COVID-19 in skilled nursing facilities. So number one would really be to restrict visitors. Of course, universal source control, good hand hygiene, cough etiquette, wearing of masks, active screening. If you do have residents that seem to have respiratory symptoms, you should isolate them immediately. You can do clustering for patients with mild symptoms. They have advised that all group activities within the home should be canceled for the time being and no communal dining should be done. You still need to enforce social distancing even in the facility. And should you be able to identify a COVID case, you should restrict residents to their rooms and provide PPE to the healthcare workers. If your facility is large enough, you can identify a location to care for the residents who have suspected or confirmed COVID-19, and it should be separate from the other residents who do not have the disease. They should have a dedicated healthcare worker team that is seeing to them, and of course, monitor and transfer to a higher level of care as needed. Next slide, please. Okay, so what about your patients who are community dwelling or living at home? So those that live with their families, if they have a large group of people living at home with them, You can advise them to be assigned a safe space, meaning a dedicated space wherein it will just be the older persons moving around that space. If they have enough family members, you can designate a family member to help take care of them. But ideally, that family member should not be the one that is going in and out of the house, running errands, or doing the chores outside of the home environment. Next slide, please. Okay, so we've discussed a lot about the physical effects of COVID-19 on individuals, but for older patients, and I think as well for younger adults, it's not just the physical well-being that is affected, but also the following. So for older adults, a lot of their social networks are actually outside the home. They belong to their church community or they're active in their barangays. Friends and families who don't live with them are part of their social networks. And with the ECQ, we're actually taking away the social networks from them. And this actually serve as a means of emotional and psychological support for them, no? Which in turn could affect their mental health. So we've seen increasingly, I mean, personally, I've had a lot of patients that are now asking me for anti-anxiety medications or antidepressants because they really feel that there is a change in the status of their mental health. I also have patients that have become more paranoid. If you just turn on the television or listen to the radio, we also repeatedly say that older people are more vulnerable, that they have higher rates of death. And so it makes them paranoid that if they feel something, they automatically think that they might have gotten COVID already. And as discussed by Dr. Nemi, a lot of the older adults are also the ones with multiple comorbidities. And so they are also the population group that need to access health services more frequently and more often. But with the quarantine status, it's more difficult for them to get out of the house and see their doctor. And additionally, a lot of them do not want to go to the hospital. So even if they don't feel well or there is a new symptom onset, they think that going to the hospital would actually make them sicker because they now associate doctors and hospitals with having higher rates of COVID infection. Of course, these are also your group of patients who are most of the time not covered by HMOs anymore. They do have PhilHealth, but anything outside of PhilHealth coverage will be out of pocket. So that is an additional worry for them in terms of financial capabilities because it will be more expensive for older persons to actually get the disease and be hospitalized, knowing that the average hospital time is about 15 days up till recovery. And of course, like we do a lot of Zoom meetings, but you know, our older patients are not very techy. So the lack of digital inclusion is also a problem for them because they are unable to communicate as well as the younger generation, since not a lot will know how to access FaceTime or Zoom or Google Meets or even use a cell phone. So they're limited in terms of how they can communicate with the outside world. And of course, lastly, older persons are not always unemployed or retired. You still have a good number of older persons, especially in your informal employment, who are still able, but again, the situation does not permit them to be gainfully employed, which makes it more difficult for them mentally and financially. Next slide, please. So this is just a summary of what I had discussed. This is actually lifted from the United Nations report on the impact of COVID-19 on older persons. And you can download this from the internet. Next slide, please. Okay, a special subgroup of older patients are our patients with dementia. We know that dementia is most often seen in the older age group. And this can present to be a challenging group of patients because with the ECQ, you disrupt what is their routine. So what we would advise for those doctors who have patients with dementia is to try to get the family to explain the situation, but clearly and simply. Something like, "Inay, may nakakahawang trangkaso ngayon, nakukuha sa mga matataong lugar, kaya dito muna tayo sa bahay para ligtas ang lahat." You need to teach them proper hygiene, such as hand washing, cough etiquette. And again, for both explaining the current situation and teaching them proper hygiene, you need to have family members be prepared to do it over and over again and be repetitive. It's important to advise your patients and their families that they should continue medications and that they should ensure adequate supply. Drugstores right now will accept digital prescriptions. So it's also important on our part as doctors to make sure that we send them the prescriptions on time and with the adequate number so that they can stock up on their medications to ensure that it is given continuously. And I know that there are doctors who do not want to give out their personal cell phone numbers, but now is not the time. Or if your secretaries are familiar with your patients, it's very good if they are able to communicate with you simply because access to healthcare and doctors is very difficult during the quarantine period. Next slide, please. So for patients with dementia, it's important to advise family members that they should maintain a schedule. It's important for them to have a routine. The schedule need not be rigid. It can be very fluid, but the routine is important because the quarantine has actually disrupted the normal schedule that they are used to. You can advise them to call family and friends, maybe one or two a day in order to maintain social relationships. If the patients are still functionally okay, you can include them in daily chores. No, give them simple tasks like folding clothes, sweeping the room, washing vegetables, so that they feel useful and that they are contributing to what is happening in the household. You can do what we call reminiscence therapy, which is show them albums and ask them to tell a story about the pictures that they see in the album. So all of this are in the Facebook page of the Alzheimer's Disease Association of the Philippines, and you can direct your patients or family members of your patients to go to that Facebook page. There are a lot of advice there on how to deal with patients with dementia during this time of the ECQ. Next slide, please. And lastly, I think it would be remiss if I didn't discuss what we call advanced care planning. I don't want to make it seem that just because we're talking about older persons, that they are also the age group where you automatically need to have DNR, DNI orders. But advanced care planning is highly recommended, especially for patients who are in the older age groups who are positive for COVID-19. But there are challenges in discussing this. So when do you discuss it? A lot of doctors are uncomfortable doing the ACP, especially for new patients or patients they have not handled before because they think that it may cause a lack of confidence in them if they start talking about death and dying right away, on initial consultation. But I think especially now, given the risks that COVID-19 also poses to healthcare workers, it's important that we discuss this. So when do you want to discuss this? If this is an old patient of yours, then I think the earlier you're able to discuss regarding advanced directives, then good. If this is a new patient, I think all patients in the emergency room that are warranted to have ICU admission, you need to discuss advanced directives. Patients on the floors whose clinical course is deteriorating, again, I think there is a need to discuss advanced directives. It can be challenging because the COVID patients who are admitted are usually alone. And so family members, we're only able to talk to them either over the phone or video calls, which makes it even more uncomfortable to discuss regarding advanced directives. But how do you do it? So, well, right now, I think there's maybe less than 1% of patients or people in the world who still have not heard of COVID. But one good way to start is to discuss it this way. So next slide, please. Okay, so one good way to begin the discussion is actually to discuss in terms of what are their priorities when it comes to medical care. Is the number one most important is to live long, regardless of the means of how they will live long. So that means even if they have to rely on machines, that is okay as long as they are alive. Or is it simply important to maintain their current health? In which case, they're willing to be hospitalized, they're willing to have certain treatments, but if other treatments will just make them worse or increase their pain, then maybe they don't want it. Or do they just want comfort care or palliative care, in which case they just want a natural death? Next slide, please. So this is a form which I actually got from a person-centered care webpage, Respecting Choices, I think. And it's actually a sheet of paper that is given to patients who are able to read and still cognizant, or to family members who have been appointed their healthcare representatives. And it explains, for example, CPR, what is done if you do CPR, what is not done if you do not attempt CPR, and talks about values. Next slide, please. It also talks about outcome of what can happen if you do decide to do CPR, or if you decide not to get CPR. No? And at the end of this form, it asks the question of whether or not they would still be willing to have CPR done. Next slide, please. There is a slide also that talks about breathing. So in terms of, do they want to be intubated, no intubation, or even non-invasive airway, they don't want it. I think for COVID-19 specifically, it would be good if hospitals have a checklist that makes it simple. And the checklist can just include, for example, we know that all treatments are experimental. So you can have a brief discussion with the patient or with family members in terms of advantages and disadvantages of being given the experimental treatments, whether it's remdesivir or hydroxychloroquine or convalescent plasma, and you can just check yes, no, intubation, yes, no, hemoperfusion, yes, no, and make it part of the chart, so that should the time comes, and knowing that there are no relatives around 24 hours a day for our COVID patients, you can just refer to that checklist and see how far do they want us to take in terms of treatment and extraordinary measures. Next slide, please. Okay, so that was my last slide. So in summary, we know that older persons are more vulnerable to COVID-19 with increased rates of severe disease and mortality. Older persons may present with atypical symptoms, so that a change in clinical baseline should merit an investigation. COVID-19 not only affects them physically, but also their mental health, economic well-being, and increases the chance of neglect and abuse. Patients with dementia are also at greater risk. Advanced care planning is important and should be done early, and age alone should not be a factor to withhold or withdraw treatment. Thank you.
Thank you, Dr. Admrao, for that discussion, including the practical tips, no, and the things that we need to know, no, particularly when we are handling elderly. Now let's hear Dr. Vimar Luz, no, for his talk.
Okay, I'm gonna share my screen now.
Okay. Yeah.
Okay. If there are no issue in the view of my slide and my sound, I would like to proceed with my talk. So the task at hand for me is to talk about the vulnerability for COVID among chronic kidney disease patients. So for the purpose of this lecture, when I refer to chronic kidney disease, I would mean patients who have at least a creatinine clearance of less than 60 ml per minute, or those patients who are pre-dialysis. It will also include patients who are on dialysis and patients who had been or who had undergone kidney transplant. I have no disclosures. I have the same objectives as the previous two speakers. And is CKD really associated with severe COVID? Well, historically, our CKD patients are really prone to both inpatient and outpatient pneumonia. And they are from the latest cohort of patients investigating, they are 15 times likely to die from pneumonia versus the general population. And then it comes to having a severe COVID, they are 3 times likely to have associated severe COVID-19. And this is very evident from the meta-analysis of initial 4 cohort of patients in China, which showed that chronic kidney disease patients who have COVID are 3 times likely to have a severe COVID. Okay, Aside from that, COVID patients with kidney involvement are 2 to 4 times likely to die. Again, this is a cohort of 1,000, about 1,500 patients, and they have looked at the renal parameters. So any evidence of increased creatinine or azotemia actually puts you already to 2 to 3 times likely to die. And those patients who have varying degrees of renal insufficiency can have about 2 to 4 times hazard ratio. Other renal abnormalities seen among COVID patients also put them at risk to die, which includes proteinuria and hematuria. Okay, so the risk factors that we have identified right now to have a severe type of COVID patients have been put among patients with old age and male patients, patients with cardiovascular disease and diabetics, and two of these have been discussed by the two previous speakers. And incidentally, these same risk factors are the same risk factors that we see for patients who are prone to have chronic kidney disease and who are prone to have progression of chronic kidney disease to ESRD. So it is not surprising that most of these patients with CKD are really at risk for having severe COVID. And this is very well described in the same cohort of patients, about 1,500 patients, wherein about 40% or over 40% of which have been diagnosed to have COVID, with kidney involvement. And we can see that for those factors identified to have the worst COVID presentation, majority of those patients are patients who are older, with comorbidities and diabetes. And those patients with chronic kidney disease who are likely to die have 9 times likely to have elevated serum creatinine upon presentation. Okay, not only that, CKD patients are regarded to be commonly immunosuppressed. Although this takes a debate in some of the literature because a certain phase in the clinical pathologic phasing of COVID would put patients who are likely to die during the hyperimmune phase of COVID. So these are very important subject of investigation right now among chronic kidney disease and those immunosuppressed patients. But locally, with a quick survey among medical directors handling freestanding dialysis centers all over the Philippines, we've seen that COVID-19 incidence rate is about 2% since the start of the ECQ. And this is just to put it into perspective, this really puts the most immunosuppressed CKD, who are the patients on dialysis, at a higher incidence rate compared to the general population. Another group of patients, the transplant patients, are recorded around the world to have 40% chance of having severe COVID disease. Okay, so aside from this, what is very important to note is that COVID has also a direct renal pathologic effect of, for the kidneys. So that COVID can have a direct toxicity towards the kidneys. And so having a already compromised kidney, if you have a chronic kidney disease, you might have an acute deterioration of this patient because of their vulnerability. Among the mechanisms of kidney damage that have been identified in the literature secondary to COVID would be the most common is prerenal AKI, which we would usually note for the mild and moderate phases of COVID infection. But what is more specific for COVID would be direct renal tubular infection and toxicity, the effect of cytokine release causing cytokine damage, organ crosstalk, and systemic effects. I'll just go to them briefly one by one. For direct tubular toxicity, it has also been found out that there is tropism of the receptors. Dr. Nemi Nicodemus, I've shown you a while ago the receptors that the virus used to attach itself to the cells. So alveolar cells is one of them which contained it, but renal tubular cells and lately even glomerular cells have been identified to contain the receptor ACE2 and the transmembrane serine proteinase and also cathepsin, which was recently identified in RNA analysis, that is also used in attaching of the spikes of the virus, have all been identified in the proximal, distal tubules, as well as the glomerulus. So this, in effect, proves the point that most of the pathological presentation, renopathological presentation of patients with COVID disease have renal vacuolization, they have loss of brush borders, cellular eridation, and also the presence of some inflammatory cells, which is pointed to you on the figure A. And lately, they have also identified, as I've said, a glomerular involvement also. And this appears as a collapsing glomerulopathy, which is similar to what we see for HIV patients. And then this is the most elegant post-mortem analysis of 26 patients. The renal histopathology has shown us the presence of the virus itself, or the viral particles in the cytoplasm of renal tubular cells, which are directed to you in red arrows, and the green arrows supposed to denote the spikes of these viruses. Okay, another cytokine release, and as I've shown you in the first light microscopic study, you have evidence of mitotic lesions, and these are deemed to be cytokine inflammatory migration into the tubular epithelial cells, and cytokine release seems to portend a bad prognosis for patients with COVID infection. So just briefly, cytokine storm syndrome are a group of disorders representing various inflammatory etiologies with the final common pathway that result to overwhelming systemic inflammation, hemodynamic instability, multi-organ dysfunction, and potentially death. And some other clinical syndromes that are also in particular considered as part of cytokine storm release or syndrome are hemophagocytic syndrome, lymphohistiocytosis, or the more commonly associated virus-associated macrophage activation syndrome. So in other words, the cytokine syndrome is not actually something that is unique only for COVID. It can be because of several types of diseases, and obviously the treatment would depend on the kind of illness. So for COVID, the target for reducing the burden of cytokines during this clinical phase of COVID would be cytokine inhibitors or removal of cytokines. So there are several scoring systems that were written previously for virus-associated hemophagocytic syndromes or some manifestations of cytokine release. And these were particularly made in 2012 during the H1N1 pandemic also. And then we also see some adaptation locally, and this was created by internal medicine training officer for Global, Dr. Selim. And we've used it to identify clinically those patients who may have a cytokine release syndrome. In the clinical therapeutic phases that is now familiar to you, that was published in the Journal of Heart and Lung Transplantation by Siddiqui, this cytokine storm syndrome would probably somewhere in the late stage 2 or stage 3, where there is hyperinflammation. And as you can see, these are the phases where you might want to have therapeutic options like tocilizumab, which are IL-6 inhibitors, or hemoperfusion, which we shall talk about later. Okay, some other mechanisms would be organ crosstalk, like a cardiorenal syndrome type 1 for patients who had viral myocarditis or cardiomyopathy resulting from COVID. Of course, the alveolar damage can cause renal medullary hypoxia for the lack of oxygen, hypic airway, which would mean increased renal vein distension. So you will have a sort of a renal compartment syndrome, which is also what we see for positive fluid balance or peripheral accumulation of fluids. And then you have also rhabdomyolysis, which is reported in some percentage of patients having COVID. And the myoglobin, which is a large molecule, can actually cause renal tubular obstruction and toxicity. And then you have the same systemic effects. And most commonly, you have the same effect as sepsis, where you would release endotoxins. So in terms of management, we still apply the same general management as we do for those patients with kidney involvement, especially for patients who have decreased kidney reserve, like chronic kidney disease patients. So there is an importance, as I have emphasized a while ago, kidney involvement portends a bad prognosis for this patient. So obviously, there is a need for early recognition of acute deterioration in the kidney function, and also the recognition of a big amount of fluid retention, which, as we know from our management among critically ill patients, portends a bad prognosis as well. So what is very important to me during this time is a good input and output monitoring, because a 10% fluid overload, which is computed as the cumulative fluid balance, which is the difference between your input and output in the n number of days that your patient has been in the hospital, versus the baseline weight on admission. So anything above 10% may actually tell you that you are already overloading this patient of fluid. Now, for some centers, there are the available early biomarkers that then utilize, as cystatin C or urine NGAL, especially if your patients still have the urine output. And then the already established AKI care bundle, as I've said, which includes early use of biomarkers, removal of nephrotoxic drugs, especially for patients with acute kidney injury component, discontinuation of ACE and ARB, and I will talk more about this later on, a management of an effective circulating volume, and of course, best to refer it to a nephrologist. Okay, so depends on the mechanism of kidney damage. Aside from the more common pre-renal azotemia, there are several treatments, and for direct tubular toxicity, there are drugs that we have already identified that works on prevention of the attachment of cells, prevents RNA polymerization, the protein kinases, antiviral protein kinases that prevents renal polymerization, and of course, anti-IL-6 tocilizumab. I'm not going to go into detail, but the most common question for us nephrologists is whether there are need for adjustment of these drugs. And fortunately for AKI, except for favipiravir, there's usually no adjustment for acute kidney injury. There remains to be, we are looking for results of trials among acute kidney injury, and we shall await those results to determine whether there's need for adjustment. There are also no adjustment for most of the drugs. For tocilizumab, there's no adjustment for patients who have greater than 30 ml per minute creatinine clearance. But in terms of adjustment, in terms of renal replacement therapy or dialysis, there are no data yet. So it is best to give tocilizumab after any extracorporeal procedure like dialysis or hemoperfusion. Now, other considerations. So in general, those who are protein bound, high level of bioavailability, those are patients, those are drugs that are not usually cleared by any form of extracorporeal therapy. Okay, just a little on hemoperfusion as an option for cytokine storm syndrome or cytokine release. So hemoperfusion uses an adsorbent to absorb toxin, drugs, and metabolites or any target molecule. So this is like a cartridge that closely resemble a usual dialysis cartridge or a dialyzer. And inside this cartridge, which is seen here as a pinkish cylinder, are resins. Okay, and on your right are the designation of the molecule. So we have the brown, which is the A molecule or the target molecule. So each cartridge that you use for hemoperfusion have specific target molecules that you want to remove. Okay, so in other words, molecules that pass through the cartridge contained in the blood that are not the target for removal of the hemoperfusion will not be removed. So only the ones which are target molecules, in this case designated as the small blue circles and the brown circles, are removed during this hemoperfusion, and the others just pass through. Okay, there are several absorption mechanisms involved for hemoperfusion, and this include hydrophobicity, molecular sieve, and most commonly physical adsorption and electrostatic interaction or bioaffinity antibody antigen reaction. So these are the resins that are present inside, and most commonly used for COVID are the immunoadsorption, like the ones they do for Europe, and the less specific or less uh, specific type neutral-microporous resin, which is the one we use in the Philippines. So the 17 years already for hemoperfusion. So this is not something that we're just using now. But in the Philippines, we've been doing it around 3 to 5 years now for hemoperfusion, and we're doing it for any other illnesses, specifically for maintenance hemodialysis, as well as patients on critically ill. So for patients who are infected, who have severe type of COVID-19 infections, we use this particular cartridge, HA330, and lately we have the new player, which is the MG350. And these are the two cartridges that are specific for cytokine removal or inflammatory mediator removal. So the setup is just easy. So you can do this either with dialysis or without dialysis. So the blood that comes from the patient, which is the figure above, is just a solely hemoperfusion. So the blood flows to the hemoperfusion, and after passing to the cartridge, returns to the patient. Now, if the patient is on a maintenance dialysis or an indication to dialyze, you can use hemoperfusion and hemodialysis or hemodiafiltration using a series or creating a series such as the hemoperfusion cartridge goes first, and then the blood goes to the dialyzer for the dialysis and then returns to the patient. Okay, so as we know, most of our treatments for COVID are all experimental, and we appreciate that there is a worldwide um, investigation on these therapeutic options, and these include hemoperfusion. So also lately we've been having a lot of webinars about hemoperfusion, and these are the following indications for hemoperfusion among COVID patients with or without AKI, and this include with or without clinical acute kidney injury component. So this include clinical signs and symptoms that is consistent with SEERS, the presence of progressive elevation of acute phase reactants, which we mostly request for these patients, ESR, CRP, ferritin, fibrinogen, and even D-dimer, because as we know, patients who have severe COVID have most likely hypercoagulability. And then any evidence of organ dysfunction, most commonly we have pulmonary, cardiac, and also other organs. And then if available, you can also use AKI biomarkers because this will show us early renal tubular destruction. In the newer clinical classification of COVID, indication for hemoperfusion would probably fall in the third clinical classification, which is a severe type, and it's featuring several of these clinical parameters, mostly respiratory compromise. So this is the simple hemoperfusion prescription. We usually do this from 2 to 4 hours. Anything more than 4 hours may not be advisable anymore. We use anticoagulation. The usual dose that we use is 10 units per kilogram per hour. So in our experience, we usually have a bolus of 500 units at the start and 250 units on succeeding hour. Blood flow should not be anything lower than 200 up to about 300 ml per minute. It can be done, as I've said, with or without dialysis. So on the first day of treatments, we do 2 hemoperfusion treatments, 12 hours apart, then once a day for day 2 and day 3. So it's a total of 4 hemoperfusion sessions in the next 3 days. The evidence, okay, so right now we don't have published evidences. Most of the evidences presented are shared experiences, but Italy and Europe and even some critical specialists from China have used hemoperfusion along with dialysis, either hemodialysis or hemoperfusion, and they've shown promising results. We have been provided by one of the manufacturers of the cartridges with this cohort study done in China, wherein they have done hemoperfusion alone, and this included 47 severe COVID patients, and it has improved oxygenation after 72 hours with these parameters and a lower 28-day mortality rate. So a lot of evidences or a lot of studies are going on comparing this. And for our own experience in global, we found it to have promising results. But however, we need still to define the measure of effectiveness in our local setting, as we don't have an interleukin 6 determination. We do have it, but we don't usually get the result quickly. Sometimes in historically, we get the result about 2 weeks to a month. And obviously that's not something we can use for critically ill patients from COVID, okay? And these are possible endpoints that we might want to use. We are doing a study right now for Philippine Society of Nephrology. The Committee on Research is doing a study now on the hemoperfusion experience for all training institutions and big centers in the Philippines. We've also seen in our experience a reduction in D-dimer, but this may not necessarily mean reduction in the thrombotic events. We've seen in our experience for the use of hemoperfusion with other illnesses that hemoperfusion tends to really impair platelet aggregation, which can be associated with the reduced thrombin formation and may in fact really result in the reduction in D-dimer. Okay. What about investigating hemoperfusion versus tocilizumab? So in terms of studies right now, these are ongoing and we are eagerly awaiting the result. What about hemoperfusion and convalescent plasma? In my opinion, hemoperfusion and convalescent plasma can be complementary. I would probably more recommend doing hemoperfusion before convalescent plasma. If you do convalescent plasma before hemoperfusion, you would have to wait, and the hematologist would recommend about 3 days after convalescent plasma before doing any extracorporeal therapy like hemoperfusion or hemodialysis. St. Luke's has been in partnership with Security Bank in the drive for donation of convalescent plasma from those who fortunately recovered from this disease. And Security Bank and St. Luke's is offering this as free convalescent plasma, especially for patients who cannot afford this treatment. So these are the contact numbers if your center would be interested. Little notes on renal replacement therapy. There's still no change in terms of our choice to dialyze patient. We still use our theoretical absolute indication. But sometimes for COVID patients specifically, we might have relative indications like increased essential fluid requirement, patients who are highly catabolic, or patients who might have cytokine storm. In terms of the choice of mode of dialysis, is it a choice between a continuous renal replacement versus intermittent? Of course, this is an age-old question, and usually my answer to this, if your patient is hemodynamically unstable, then the patient might do well with continuous renal replacement therapy, especially if there's an increased requirement of fluid. You can add on hemoperfusion, especially if you have evidence of cytokine storm syndrome. Now, in the US, they are geared towards doing hemofiltration alone, while in Europe, they are geared towards doing hemofiltration and hemoperfusion combined. But in the Philippines, obviously, this is something that we have to think about because of the economics. Peritoneal dialysis is always a viable option. Of course, it has the advantage of not exposing healthcare workers because an independent patient can do this. However, we have the limitation right now in the Philippines of the availability of PD solutions. So we cannot just do PD in the large scale basis as we do hemodialysis right now. So in general, the choice will depend on your practice and should be individualized for each patient. Also, there's this concept also that I want to discuss about increasing clearance delivered versus frequency or decreasing frequency. For instance, let's say CRRT, which is expected to be attached to the patient 24 hours a day, might increase the risk of your healthcare workers being exposed to the critically ill patients with COVID 24 hours a day. So some of the recommendations right now is to shorten that continuous renal replacement therapy into about 10 to 12 hours, but with a higher dose delivered between the 10 12 hours, usually about 50% more than the prescribed as we have for other patients. Also, there's initial recommendation previously of decreasing frequency of dialysis, but this has to be taken cautiously and should be individualized because as much as possible, you do not want to under-dialyze your patient because this might result for them to increase morbidity and cause them to be admitted in the hospital, which you do not want at this time. Frequently asked questions, and I base this in the Center for Disease Control list, and I just chose 4, which may be significant for all of us. Where should patient be dialyzed? Ideally, patient should not be moved anywhere. If you can dialyze patient in the patient's room, and if there's a provision, possibility for you to do the dialysis in the patient room, so much better. You limit the transport, and of course, your HD nurse should have the complete PPE. For HD unit, if you want to dialyze them in an AC HD unit, there should be an isolation room or at least cohort them to a place, like in our case in St. Luke's, we usually put the patient in the temporary admission in the crit care areas where our COVID patients are. Okay. If you don't have that capability of isolation room, you can practice cohorting, which I shall show which shows some indigenous abilities by our nephrologists to adapt on this aspect. So what is the recommendation for cleaning and disinfecting? The current recommendations for cleaning are adequate. And then there's also a controversy of reuse of dialyzers for the benefit of healthcare workers. We'd rather that we do not reuse dialyzers. But of course, in freestanding dialysis, where most of our poor patients come in, the reuse of dialyzers can, not reusing dialyzers can become an issue. So this should be a cause for discussion with your patients who are positive for COVID. So how to dispose CRRT, it's the same as standard protocol, except that whoever's doing the disposal should have a complete PPE. So this is important that I want to emphasize. What are your discharge plan for COVID patient? Please endorse properly to dialysis facility so that the dialysis facility can be ready. And you do not want your patient hanging there, because the reason why I want this endorsement, because we've already been seeing a lot of patients who are turned away or discriminated from their own dialysis facility. So we want this to be thoroughly and adequately endorsed to the proper dialysis facility, please. Okay, prevention, strict quarantine, of course, for those with vulnerable patients, CKD, just like recommendation of our 2 previous speakers, your CKD or pre-dialysis patient, patients on PD and KT patients. But obviously for those regular HD patient, quarantine is not an option. Okay? So consider online consult and telemedicine for follow-ups with this patient. There's no need to stop certain medications like ARB and immunosuppression, and I'm just gonna discuss that briefly later on. This one. Okay, so this was mentioned a little bit by Dr. Nicodemus. So if you do not use ACE inhibitors or ARBs, the process of availability of angiotensin type 1 receptors become increased. And so this may result to increased acute lung injury, adverse myocardial infarction, myocardial remodeling, vasoconstriction, and vascular permeability, which obviously portends a bad prognosis for patients with COVID. So during infections with SARS-CoV, where it was told to you a while ago that the ACE2 receptor is the primary receptor for COVID, the downregulation of ACE2 in the absence of ARBs or ACE inhibitors makes the angiotensin 2 receptor quite available for angiotensin, and this will result to the catastrophic events enumerated. So, abrupt withdrawal of RAS, although in the initial investigation I've recommended removal it, we still do not want them to be removed, especially for those patients with adverse outcomes like patients with heart failure or previous myocardial infarction. Withholding should be properly individualized, especially for patients with decreased effective circulating volume, hypotension, those with worsening pre-renal azotemia. A discussion with the cardiologist or with other specialty should be done in withholding these drugs. There's now a trial that has been registered in the clinical trial investigating losartan 50 milligram as protective of COVID-19 infection, and their outcomes of investigation as primary is the PF ratio at 7 days, with secondary outcomes investigated including acute kidney injury. So again, in terms of prevention, we want to practice cohorting, which I've emphasized a while ago, of symptomatic patients or COVID patients in the absence of isolation room. And this is how indigenous our nephrologists have become, especially for freestanding dialysis. So we put all those patients on the last shift of that day, those who are suspect, probable COVID, or those with COVID positive infection, and we create some sort of a barrier which you can do. And obviously these barriers needs to be cleaned or changed every day. Okay. PPE should be emphasized, especially for HD patients and healthcare workers. So strict PPE must be advocated, and PSN has launched a drive and still accepting for donations for PPE, especially for centers or hemodialysis centers advocating the dialysis of COVID suspect and COVID positive patients. So you can still contact us for that. We also advocated mass testing, and I want to emphasize again and requesting from the Department of Health that we are requesting, especially for our dialysis patient, to be tested. And this has been a request from the society during the meeting with the Department of Health. What about transplant? Okay, so at this point, these are the usual opinion from the different groups that I've attended on webinars. We want to limit KT only for those patients who have immediate need for kidney transplant, like patients who have no access already for dialysis, or patients who have no access for peritoneal dialysis. Should you be doing transplant, we only want the standard risk patient, for the simple reason that high-risk patient would use polyclonal antibodies that may make them more immunosuppressed in the coming 3 to 6 months, and we don't want that. Okay. No disease organ donation, as we have already documented a community transmission, so not at this point. Okay. So in summary, patients with chronic kidney disease are 3 times likely to have severe COVID. The risk factors and comorbid conditions associated with increased mortality or severe kind of COVID patients are also associated with increased risk of having CKD. CKD are also at increased risk for acute kidney injury, and I have enumerated several mechanisms in the pathogenesis of acute kidney injury on top of a possible CKD. Hemoperfusion provides a specific form of clearance of inflammatory mediators and cytokines among patients who have clinical diagnosis of cytokine storm syndrome. Its timing and indication is still a subject of further studies. The choice of renal replacement therapy for patients with COVID-19 must be individualized, considering not only clinical outcomes, but the safety of the healthcare workers doing the procedure. And just like the previous speakers, we have emphasized the importance of ECQ among these vulnerable patients, cohorting dialysis patients, cohorting COVID positive or COVID suspect to protect the other dialysis patients, especially for hemodialysis patient, and strict PPE protocols among the healthcare workers and wearing of masks for hemodialysis patients. That's the last of my slide, but this is the most important of the slide. I want to thank my colleagues from Global and QC St. Luke's Medical Center for sharing the practice with us during this pandemic. Our crit care IM hospitalist ER consultant, especially our IM residents who have experienced this pandemic at a very early age. A big shout out to our scientific committee and COVID research group in St. Luke's Medical Center Global, and these are the names of these brilliant and collaborative doctors that we have in our approaches, in a multi-specialty approach to patients with COVID-19. And finally, I would like to thank the medical directors, renals, technicians, and staff of our frontliners in the hemodialysis centers and the Philippine Society of Nephrology Board and PSN Committee on Research for supporting our research for these vulnerable patients. Thank you very much.
Thank you, Dr. Vimar Luz, for that extensive talk, and of course for mentioning about the management, particularly among those who develop severe illness. Now, of course, there are many questions here, and I thank, of course, Dr. Nicodemus and Dr. Dumlao for answering a few of those questions. Let me go on one other question here. How frequent or how high is asymptomatic COVID-19 among these groups of patients? The elderly, as well as diabetes and obese, and of course among those with CKD. Sandy, do you have information about asymptomatic COVID-19?
No, unfortunately, I tried to search for that data, but neither DOH nor the WHO has data on asymptomatic individuals. I think the limitation is just that because the elderly are quarantined at home, and if they are asymptomatic, then the presumption really is they don't have the disease. So they don't get tested.
Well, yeah, thank you. What about diabetics and obese? Nemi?
Unfortunately, because we are not testing everyone, we're not doing any expanded testing as of now. I don't have data to show how many of the diabetics who have asymptomatic COVID. So it's hard to.
Of course, for CKD, Vimar?
I think I've mentioned in the lecture, I did a quick survey from the medical directors of the most vulnerable patients or the hemodialysis patients who cannot have quarantine. Considering the same general threshold for testing between general population and hemodialysis patient, at the same time, we have a higher incidence rate of COVID-19 for patients on EPS compared to the general population, which stands now at 2% compared to about 0.12 to 0.15% of the general population. Of course, this might increase depending on the widespread mass testing, which, as I've said, been recommended, and we're asking the Department of Health to support the Philippine Society of Nephrology in the testing for our dialysis. Dr. Nemi.
Sorry, Sandy. There's a question here from Dr. Shelly De La Vega. How can we ensure that the public and private nursing homes and residential care facilities for the elderly are properly reporting COVID-19 cases?
So I think that's quite challenging because number one, the nursing homes here in the Philippines are not under the Department of Health. They are not considered healthcare facilities. They're considered repositories. So they are under the Department of Social Welfare and Development. I know that there is an agency that is tasked to monitor them, but not all are registered under the DSWD. So I think we just need to appeal to the owners of these long-term care facilities and nursing homes to ensure that proper reporting be done, whether it is to their RESU or to their local government units or even directly to the DSWD. But right now, I don't believe that there is actually a task force that is formally monitoring this. I've not seen any reports.
Thank you, Sandy. Nemi, of course, you've talked about diabetics who would have higher risk of developing complications as well as higher risk of developing COVID-19. No? Now, there are, of course, lots of complications related to COVID-19. And so when these patients develop severe illness, how do we optimize sugar control for this particular group of patients?
Yes, of course, the response of the body, particularly in a diabetic individual, is to increase stress hormones. And we all know that even in the absence of steroid treatment, the patient with diabetes and infection will already have uncontrolled hyperglycemia. The best treatment so far, at least for those who are critically ill and admitted in the hospital, is of course insulin, whether it be via the subcutaneous route or intravenous route, depending on their clinical state, would be the question. But for those patients with mild COVID-19 who are well controlled with their oral anti-diabetes agents, then perhaps they can continue with their oral anti-diabetes agents, although there are certain drugs that we do not recommend, like, of course, our SGLT2 inhibitors, because they will cause some degree of dehydration among our patients. And at this point that they have infection, we don't want them to get dehydrated.
Thank you. Thank you, Nemi. Vimar, you mentioned about cytokine storm. No? Is this frequent among CKD patients undergoing dialysis when they develop COVID-19?
Right now, we don't have the incidence, but we are, as I've said, doing studies right now for patients who have had kidney complications, and we are surely awaiting the result of that. But we've seen this more common for those patients who are critically ill in our practice.
And certainly that's the time that we can give the alternative options that you mentioned, including, of course, tocilizumab as well as hemoperfusion and the rest, right?
Also.
And again, these are all investigational. We still don't know if these drugs or agents or interventions can really work. No? That's why we're doing studies on this. No? Now,
yeah. And at this point, we should always encourage a collaboration with other multi-specialty when talking about these therapeutic options and opening it to the patients and patients' family.
Sandy, of course, there was a talk recently that I heard in Europe, primarily because doon matatanda na talaga, about 80 years old, get sick. And certainly many of them will die because of heart attack. And certainly it was, of course, assumed that this is also one of the risk factors why these patients actually die immediately. But somehow, during their observation, marami rin late magkonsulta, And I think that can also be a problem in our setting, Is that correct? What's your comment on that? Because of the late consult, maybe these are complications that can emanate even because of from their pre-existing illnesses, not related to their age.
Yes.
Not really, because of the age, yeah.
So, like I mentioned, the access to healthcare, normally it's really your older person patients that would need more frequent checkups. And given the limitation of transportation to get out of the house, to get to the doctor's clinic, plus the fear of actually going to the doctor or the hospital, so that there are actually an increased number of cases also of morbidity and mortality at home of our older patients. And one of the challenges that we saw in the past 2 months is actually for older patients that died at home, funeral parlors will not take them unless somebody validates that it is a non-COVID death. So I think maybe mortality is also underreported for this age group because of those patients who expire at home simply because they were unable to or did not want to go to the hospital or see their doctors.
Yeah. Thank you. Thank you, Sandy. Nemi, syempre, yung obesity, no? I'm of course very interested in that. I saw that there's definitely a link, no, with severe COVID-19. So, of course, sasabihin natin, no, kailangan mag-diet kayo. But at this time, nakastagnate talaga sa bahay dahil ECQ, no? How can we actually uh, advise them on the other measures to prevent COVID-19?
Right. Of course, syempre yung pagda-diet at this point, probably it's very difficult to do. The fact that they are at home, they are less mobile, and the fact that they have limited choices for food, no? That's why we would encourage na sana yung home cooking na makakapili talaga sila ng medyo mas healthy type of food. But of course, similar to anyone who might be at risk of being infected with COVID-19, these people should, of course, practice social distancing, wearing masks, making sure that yung hand hygiene is always practiced. And other than that, they just need to make sure that their bodies are relatively healthy by ensuring that they become more physically active at home. Na doing minor exercises, even as simple as walking, may do.
Yeah, kaya maganda naman ngayon nag-modified ECQ. Walking can definitely help, no? Mahirap talaga naka-stuck ka lang sa bahay, nakaupo, nanonood ng Netflix. Anyway, I'm not sure if there's still many other questions, but I think there's just a question here in terms of the other non-pharmacologic interventions, like yung dati sinasabi that you really have to take a bath every now and then, no? But of course, when you talk about those with comorbids, especially the elderly, na minsan medyo tamad maligo, no? So should we advise them to really take a bath and practice hygienic measures every now and then? Sandy?
Yes, even if it's not a pandemic, we should encourage them to practice proper hygiene all the time.
Yeah. Sa mga CKD patients ba, meron pa ba iba tayong ma-advise para sa kanila to prevent, no, this COVID-19?
Actually, the most important to emphasize is equality. Do not let them go out. Yeah. Because as we see, we are the more vulnerable population. Wearing of the mask is paramount for this patient. In general, I think that we can agree at this point that prevention is the best when it comes to this group of patients.
Nemi?
Yeah, I definitely I agree with our two speakers that personal hygiene is very important, whether with the pandemic or not, but more importantly now, of course.
Okay, so thank you very much. I think there's one question here that's also very important in terms of preventive na sinagot naman ni Sandy, no? But I think I need to share it. Vaccination certainly is, of course, encouraged, particularly for flu and pneumococcal vaccines. And of course, when we talk about vulnerable population, siyempre, importante ito. No? That's a way to prevent other infections that we can actually get, no, when we talk about COVID-19. It's not only COVID-19 that's a problem, we can also have to think the other infections as well. Again, maraming salamat sa inyong tatlo. Any parting words from the three of you? Yeah. Sandy?
No, I just want to encourage our older persons or senior citizens that as much as possible, please stay home. It's not about the civil liberties that we're taking away. It's really about keeping you safe and healthy for as long as possible.
Vimar?
I just the emphasis for mass testing among hemodialysis patients is one point I wanted to make, and I want to push because as we have seen asymptomatic carriers among the general population, we are testing the general threshold right now in hemodialysis patients is just to test those who are symptomatic. And if we have seen in the general population and seeing that the incidence rate right now for hemodialysis is higher than the general population, I would suppose that we have an increased risk among healthcare workers handling freestanding dialysis units to have COVID also because of these asymptomatic carriers. And these are carriers that you cannot do quarantine. So that's, I think, the last message I would like to emphasize. Thank you.
Nemi?
Yes, just 2 points. One, for our patients, we must ensure self-care, take care of your diabetes, take your medications, monitor your blood sugar. And then number two, for healthcare providers, of course, knowing that diabetic patients and those who are obese are at increased risk of severe infection, make sure we do encourage them to consult if they have symptoms, and make sure that we control their hyperglycemia and other comorbid illnesses. Thank you.
Again, thank you very much, Dr. Adumlao, Dr. Luz, and Dr. Nicodemus for this particular webinar session. And I'd like to, of course, invite everybody on Wednesday. We'll talk about COVID-19 in pregnancy and in children. So again, see you this coming Wednesday, and bye-bye.
Thank you.